Well, good morning again, and welcome to the 4th Houston Methodist Town Hall conversation on COVID-19. I'm Dr. Alan Lumsden, the chair of the Department of Cardiovascular Surgery in the DeBakey Heart and Vascular Center at Houston Methodist. It's truly my pleasure to welcome you again to the Houston Methodist DeBakey CV Education Studio, named after one of the greatest cardiovascular surgeons of all time, Dr. Michael DeBakey. I want to thank our more than 500 guests. We wrote this yesterday. We believe it may be over 700 guests who are joining us via live stream and on our conference call line. These guests include members of the Society for Leading Medicine, members of the President's Leadership Council, members of our Premier Care and Platinum programs, lead benefactors, and the many other friends of Houston Methodist. Welcome, and thank you again for spending your morning with us. I'd like to hand it over to Dr. Boom to moderate the session.
Thank you, Dr. Lumsden. It's really great to see everybody here today. Thank you for joining us in now the 4th of these sessions, and thank you for the amazing attendance. It's an interesting time in Houston right now, and we're going to be talking about some of what we're experiencing, and I've brought along some amazing experts today to talk to you. First, let me introduce a man who you've met several times before, Dr. Dirk Sossman, who is the president and CEO and our chief academic officer for the Houston Methodist Academic Institute. He joins us virtually today, and we're delighted to have him with us. On my left, I have Dr. Khurram Nasser. Dr. Nasser has been with us, I think it was October you got here, yes. So he's still pretty new to Houston Methodist, one of these, luck favors the prepared mind kind of situations, because we brought him in October as a very high impact recruit who's really fundamental in our response right now to COVID. He is co-director for our Center for Outcomes Research. So as we look at COVID and the outcomes on our patients, many of the studies we've done, and the future, which he will be talking about today, he really brings a tremendous amount to the table. He is a member of our Gerald B. Katz Academy of Translational Research, and so we thank the Katz family for the generosity in helping bring him to us. And then, of course, Dr. Lumsden, who has already introduced himself, who needs no introduction, and he's going to lead off today and fill us in a little bit. Dr. Lumsden.
Thank you, Mark. So the task that I was presented with was to talk about the COVID impact on emergency care. And so what I want to do is to, give a little review on some of the background symptoms which patients actually present with. And what we're trying to do is, there were many questions which the audience sent in. And some of the responses to those questions we're going to try and embed in our presentations, and highlighted in that box is the response to some of those questions. But let's back up just a little bit and say, what are the symptoms that people generally present with? And I think we've all are aware of the fact that you get fever at about 88%, hence the reason that we screen patients who are coming in and out of the hospital in particular, but in many other sites. This has been pretty labor intensive, and it's really involved deploying our nursing staff to actually perform this. But we recently introduced an automatic way of doing this. So all the doctors, as we come into work, we stand in front of an iPad. There's a special app that will screen whether or not we've got a temperature and give you kind of the thumbs up if you're good to go to work. But fever remains the most common of the presenting symptoms. Fatigue, 38%. Fever with chills in about 11%. But you can see on the diagram to your left, one of the questions we had was, how does it affect other organ systems? And you can see that headache, not at all uncommon, nasal congestion, sore throat, dry cough, productive cough, shortness of breath. Again, that's one of the elements of COVID, is the way that affects the respiratory system. But it can also present with some of the GI symptoms. Early on, there were a lot of reports about the GI manifestations of COVID. And some patients get nausea and emesis, 5%, diarrhea in 4 to 14%, and just general aches and pains or myalgia that sometimes occur. However, some patients are completely asymptomatic. We've actually had 2 of our faculty members who tested positive, and both were essentially minimally symptomatic and were shocked when their test came back basically as positive. And so really there is an enormous gamut from the asymptomatic all the way up to the critically ill patient. And one of the questions that was posed to us was, is there any kind of different symptom complex that we see in elderly patients? And they can certainly get all of the ones which are highlighted here, but fatigue and confusion are two of the hallmarks that we often see a little bit more in the elderly. One of the questions was, is there anything that an elderly person can do specifically to try and reduce the risk? And really it's about deploying the usual safety measures, and if at all possible, stay home. But along with staying home and being socially isolated, there are a whole series of other concerns which arise regarding depression and just the general impacts of social isolation. And so that is where, if you need be, get your grandkids to show you how to use social media so that you can continue to have those kind of interactions, which really makes us who we are in terms of human beings. If you look at the mortality in COVID-19, and what we're looking at is different age ranges from on the left, 0 to 9. Of course, that's highly relevant in the moment for the discussion that's going on about reopening our schools, all the way up into the over 80, where in China there was about an 18% mortality rate associated with it. So there is clearly an age-related risk that is associated with the development of COVID-19. That is not all comers. Again, if you look at people in their 70s to 80s, they spend a huge range in terms of their physiologic capabilities. And there's no doubt that those who have comorbidities, and many of those relate to the cardiovascular world that you're probably going to hear a little bit more about from Dr. Nasser, age, high blood pressure, diabetes, heart disease are significant comorbidities that increase the risk in those patients. And there was an interesting article in the Wall Street Journal. They called it the COVID age penalty. Clearly, in the elderly population, we want to be extra vigilant in terms of the safety measures which we utilize basically on those patients. Now, what about cardiac involvement? Well, you know, a lot of patients who are severely affected with COVID have what we refer to as multi-system organ failure. It's a disease, really it's found in many sick patients where it affects the lungs and affects the kidneys and affects the heart. And so in the COVID spectrum, there's a lot of background things which are going on, such as this hyperimmune system basically, which is fired up and causes this excessive inflammatory response, which you'll hear more about. And one of the areas that's been particularly affected, which you've heard more and more about, of course, is respiratory failure and the fact that your oxygen levels tend to drop. And that was one of the screening tests which was used early on, is just looking at what we call your percent oxygen saturation. And when it drops low, you know, that is a marker of severe lung disease. But there also is some patients who suffer direct myocardial injury. Exactly what that mechanism is, whether there's an independent mechanism or it's simply a manifestation of this background hyperimmunity, remains to be determined. How does that affect the cardiac patient? It affects them because they often have a reduction in the pumping effect basically of the left ventricle, so that we get a fall in what we refer to as the ejection fraction. We can measure some of those biomarkers by drawing blood from you and see that there's a background incidence of cardiac injury. Some patients develop abnormal heart rhythms. And we've also seen an increased incidence in some of these patients with acute coronary syndromes, and we'll talk a little bit more really about that. Now, let's look at the impact that this has had basically on our surgery practice and on cardiology clinic visits. The blue bars represent when you come into the cardiology office and are seen in person with a cardiologist. And you can see at one end of the spectrum, we were 100% in-person visits. Now, I can tell you that I went to a telemedicine conference several years ago that was hosted by Toby Cosgrove. He was the CEO at the Cleveland Clinic, and he was very into telemedicine. And he said, "Is there a problem with telemedicine?" He says, "Yes, there is." And he pointed to the doctors and he said, "It's you." So it works fine. And so we had telemedicine capabilities in our clinics, but the application of that, because we as a group of physicians kind of felt like we had to see you and touch you and interact with you. And so there's this massive shift which occurred, not just at Methodist, although I think we were very well prepared for this, but in many other institutions around the country. And so if you look at phone visits or virtual visit means we can actually see you. This can actually be done on FaceTime, or our preferred route is through the modules which are present in Epic. And you can see there was a reduction in the total number of visits, but a marked increase in the number of virtual visits which we were actually utilizing. And you can see that after the initial wave, we actually picked up again fairly rapidly, and a lot of patients started coming back in to see us. So that's pre the current epidemic. Now let's look basically at what happened to our surgery schedule. And this is just looking at outpatient surgery cases. Inpatient affected a little bit less, but nevertheless very similar trends from early March, April. It almost goes to nothing compared to the fact that we're typically used to doing 230, 240, sometimes a little bit more in terms of outpatient surgery cases per day. But we were really reassured that this rebounded, fairly well. And one of the areas of focus at the moment, despite the fact that we have an increased number of COVID patients, is try to keep this surgery schedule going. And there are many reasons for that. And here's one of the reasons. If we look at what happened in the number of patients, these are absolute numbers. So typically we were going to see what we call acute coronary syndromes in red, top bar. These are heart attacks. These are patients who basically come in here with a heart attack. They're pretty well documented, so these numbers are pretty solid. And you can see all of a sudden that we dropped from over 200 in January to way down to 47 in the midst of the first wave. Now this really doesn't make any sense, because when I showed you all of the inflammation, and we'll talk about hypercoagulability, excessive blood clotting, we would have expected this actually to be going in the other direction. And the lower chart basically is with stroke. And you can see stroke goes from 85 down to 22. Now what is similar in both of these situations is that strokes occur because of blood clotting. And heart attacks occur because of blood clotting. There may be some narrowing in the arteries, but blood clotting basically is the final thing that blocks the artery off. And both of these are time dependent in terms of our ability to reverse what is going on. We are measured in time, how long it takes us when you arrive at the door of the emergency room to the time that we get a wire across the lesion on your coronary arteries and open up that artery. There are national benchmarks for this. So we measure the effectiveness really in terms of minutes. So to see this drop, is really disturbing that patients are actually going to be staying at home. Now let's look at my world where we deal with aortic dissections. The little diagram shows you what an aortic dissection is. I describe to patients an aortic dissection, it's like my sleeve here. We have the inner sleeve and the outer sleeve, and normally they're fused together. Now when you get a tear on the inner sleeve, blood flows between that sleeve and rips your jacket apart from your shirt sleeve, and that can extend all the way down the aorta. Now, if you talk about something as a time-dependent mortality, we measure this as 1% mortality per hour. And so again, there is no reason to believe in the COVID era that we would see less of these. And yet this is data from New York. And you can see pre-COVID, the numbers that they were seeing, and there was a huge drop in the number of these patients who were presenting to the New York hospitals during the peak of the epidemic. So how can we explain this? Well, if you look at the Houston Fire Department, I want to thank Bill Zogby for giving me these slides. For those of you who are part of the Heart Center Council, well, I've seen a couple of these slides before actually. But if you look at the Houston Fire Department, the number of people who are DOA, that's not a good thing to be. That means dead on arrival. You can see how it actually picked up. And so we fundamentally believe that people were not coming to the hospital. They're so terrified of COVID that they're not addressing their underlying health issues. And again, when EMS is called at home, what they do is they try to resuscitate you, and they can measure the number of patients who they are unable to resuscitate. That usually means you've waited too long to call them. Most patients, if they get there pretty early, can actually be resuscitated. And so you can see the number of patients who were dead and the number of patients they couldn't even reverse it actually went up at that time. And so we were very concerned that people were not coming to have their underlying health conditions identified and treated. And this paper really was talking about stroke and COVID-19. And so if we look at the distribution of what's a little different was that patients with signs of stroke were delaying coming to the hospital for fear of getting the coronavirus. And again, to emphasize, for both heart attacks, chest pain, and for stroke, slurred speech, can't really move your arm or your leg, typical examples, there is a finite window of time by which we can reverse that. And that is not measured in terms of days, that is measured in terms of hours. And so we relish this opportunity to reinforce that there's no point basically in avoiding the hospital when you're worried about COVID, where we think the risk is relatively low, and people are succumbing at home from advanced cardiovascular disease such as this. The mortality rate in COVID-19 stroke patients who presented were 42.8% versus 5 to 10%. You're almost quadrupling the incidence, the mortality rate associated with it. And interestingly, 42% of stroke COVID patients studied were under the age of 50 versus 75% in normal times are over the age of 65 in the non-COVID era. And so there also is a difference in the distribution basically of the strokes which are actually occurring. And so one of the questions that we were asked is, should we all be taking aspirin? Well, I'll tell you, Dr. Nasser over here, there's not a cardiologist, CV surgeon I know who's not taking aspirin or some sort of anticoagulant on a daily basis, because we believe it's just the vitamins for the blood vessels. We believe you're only as old as your blood vessels. And it's really, when you think about it, whether it's stroke, it's a blood vessel problem. Whether it's your heart, it's a blood vessel problem. When it affects your lower extremities and you can't walk, it's a blood vessel problem. So we're all about vascular health, and by and large, unless you've got a contraindication to it, aspirin, we think, should be in with the water in Houston. The common denominator to a lot of these things is probably this background coagulation problem that's going on in COVID. And some patients vary from having just devastating, what we call disseminated intravascular coagulation. It is this overactivity of the coagulation system where both we got clotting and we've got dissolving clots, basically all going all at the same time. It tends to consume your clotting factors. Most people don't get this, okay? Most people are really sick when something like that happens. But we also run the vascular lab here, which does ultrasound and diagnoses a lot. The front line test for diagnosing blood clotting is an ultrasound. And so we've seen a significant increase in the number of people who are presenting with clots in their legs, deep venous thromboses, and also upper extremity clotting. And so this clotting basically can affect all of these different systems really that I've talked about. And again, we don't want everybody to be screened with ultrasound unless we think there's a clinical indication, because both echocardiography, when we're using ultrasound on the heart, and when we're doing ultrasound on the leg, is a very hands-on personal experience. Our techs spend a lot of time basically in front of the patient, obviously the COVID patients in this situation, and are somewhat at risk. And so there is a background clotting problem in COVID. This can be measured. Some people get devastating DIC, but a lot of other people get this subclinical clotting, which is actually going on. You don't have to read this slide, but it really relates to the fact that although we want to continue to run the surgery schedule, all patients who come into the hospital are tested for COVID. They're tested a maximum of 5 days before they get to us, and then have to self-isolate. And one of the reasons is that patients who convert and are COVID positive have a much higher mortality rate when we actually operate on those patients. So we really don't want to be operating on patients. In fact, we deal with this every day. Actually, I was called yesterday about a patient of mine who's scheduled for Friday. It was COVID positive. Obviously, you weigh up the risks versus the benefits, but in that situation, the benefit is to delay his surgery for at least a couple of weeks. I wanted to address a couple of other questions that were addressed specifically to me, what are the outcomes in transplant patients? That's an area that has been of great concern. The transplant patient is a little bit more at risk because of two things. Number one, they are immunosuppressed. And number two, basically, there are a lot of people who interface with the transplant patient. We've been concerned enough recently that we have basically in the lung transplant and the heart transplant program that we have started slimming down the number of patients we are considering because of risks to those patients. We have seen a number of them convert basically after their procedures, and so we're really only taking the high status patients often who are in the hospital and have a very high mortality rate untreated. Another question that was posed to me was, should I delay my colonoscopy? The short answer is, colonoscopies is not something, there's no sort of very few things such as an emergency outpatient colonoscopy. I think basically I would not delay my colonoscopy, but if you flex at 1 or 2 months, it's really not that big a deal. But you just don't want to lose track of these things. And that's really what happens that we're concerned about, is that these things get put on the back burner and they never actually happen. So we're kind of running business as usual, particularly as an outpatient service here at the moment, and that would include colonoscopy. And so do I think you can come here and get your colonoscopy safely and be confident of that? Absolutely. So with that, I think I'm going to finish with the concerns about patients not presenting were high enough to kind of this national campaign basically was initiated by the ACC, really talking about how important it is that patients do not ignore these signs of heart attacks and stroke. And if there's one message I'd like to leave you with, it is focus on that. Let's not lose the opportunity, because many of these things are completely reversible if we see you in the appropriate time period. So thank you very much for the opportunity to talk.
Thank you, Dr. Lumsden. I will note that every single patient who comes in, unless they have a contraindication, is on a blood thinner as part of our protocol here for the very reasons you talked about. So speaking of protocol and speaking of treatments and vaccines, Dirk Sossman's going to give us an update now on both treatments and where things stand with vaccines. Dirk?
Thank you, Mark. I hope everyone can hear me okay. It's a pleasure to be with you all again, and I'll give you an update on some of the clinical trials that are going on at Houston Methodist, as well as some of the quite interesting and occasionally controversial things that are going on around the world. So the first slide shows our status in the convalescent plasma trial. And as you know, this was something that Houston Methodist pioneered the application to COVID-19. It's since become a very widely studied treatment around the country and around the world. The FDA only allowed us to apply this treatment to people with severe, life-threatening COVID-19. Probably not the group that could be the most helped by the convalescent plasma, but we had to follow the rules. So far, we have treated 347 patients. Of those, we've discharged in a healthy state, almost 300. And we've actually now bumped up against the limit of how many patients the FDA would allow us to treat, which is 350. So we're having to go back to the FDA to apply to do more patients. And in this application, we're planning to ask them to allow us to extend the treatment, not only to severely ill patients, but to those who are earlier in their hospital course, earlier in the course of the disease, where there are fewer immune complications. And we think that this treatment will be best suited for that group of patients. Another really, really interesting and encouraging thing about antibodies is shown on the next slide. These are two trials, one of which is currently recruiting, the other of which is just about to start recruiting, sponsored by the Regeneron Corporation and the other one by Eli Lilly and Company. And these are clinical trials of monoclonal antibodies. It's the same principle as the convalescent plasma. If you give a patient an antibody that someone else has made, whether it be a convalescent antibody that was made by a patient's own body, or whether it be a monoclonal antibody that was made in a pharmaceutical factory. And if you give these antibodies in a higher dose and earlier than your own body can make them once you're infected, that you can get a jump on the virus and start to clear it out while your own immune system is beginning to rev up. The basic principle of a monoclonal antibody is that it's a very, very pure form of an antibody against a single or a couple of antigens. And if you look at the panel in the middle of the slide, there's a circle with a bunch of different colored dots. That would represent what the antibody population of a convalescent plasma sample would look like. Many different kinds of antibodies against different parts of the virus. What they do when they create a monoclonal antibody is look for the antibody that has the highest binding strength and the greatest capacity to neutralize the virus. They purify that, they concentrate it, and then it can be stored and freeze-dried and used like a drug. So we are just beginning, with these pharma companies to do these efficacy trials. The safety trials show that these are quite well tolerated. And if they prove to be efficacious in combating the disease, they can be used for treatment, but they could also be used for prophylaxis. They don't hang around the body for more than a couple of weeks, but you can imagine there could be circumstances where you've been exposed to a patient with COVID-19, but you're still feeling okay. Or you have to go into some kind of high-risk situation. This could be something like a temporary vaccination. So we're quite excited about these trials. We have high hopes for them. The other thing we're continuing to look at is antiviral drugs. The remdesivir trial, which you've heard a lot about, has been completed. And we're now looking at two oral medications that are antivirals. The one that we're looking at in inpatients right now is called favipiravir, and it blocks the same step that remdesivir blocks in the copying of the viral RNA. Now, that doesn't guarantee that it's going to be as effective as remdesivir. That's why we have to do the research. But we are currently recruiting patients who are in our hospital, and we've got hopes for this. There's an outpatient trial about to start up with a medication called ivermectin. Mechanism of action less well understood, but there's some really intriguing data that suggests it may be effective against COVID-19. As you've heard a couple of times, and as you can see on the next slide, one of the big problems with this disease is this very profuse and overexuberant immunological response that can make people just a whole heck of a lot sicker than the actual virus itself. And so a lot of work has been done and is being done to try to deal with this issue. So we have currently 5 different ongoing trials of these approaches to modulate the immune response and try to damp it down when it's gone crazy. Of course, we don't know the results of any of these trials, but I think from those that we have seen the results, for example, the sarilumab trial, we're not getting a lot of huge responses here. Next slide. So I'm going to turn from the trials that are actively going on at Houston Methodist, and I will also point out that we've got several that are in the hopper, so to speak, that will be coming on over the next few months. So let me tell you something about remdesivir. You've already heard about the trial that was published in the New England Journal, sponsored by the National Institute of Health. Very carefully conducted, randomized, double-blinded, placebo-controlled clinical trial, really the gold standard for clinical evidence. And they showed quite convincingly that it shortened the time to recovery for inpatients. And there was a very tantalizing trend that was not quite statistically significant for a reduction in mortality, right on the edge of statistical significance. Well, just recently, an announcement has been made of a paper that has not yet been peer-reviewed, showing a less stringent study design in a different group of patients with remdesivir, looking at 312 people with an open label. That means everybody knew what the patient was getting, trial. And instead of using a placebo control, they went back and looked at patients who did not get the drug and tried to select a group of patients who matched those who had gotten the medication in important characteristics like age, gender, obesity, comorbidities, risk factors, and so forth. In this trial, remdesivir reduced mortality by 62%, which is obviously quite an eye-popping number. My guess would be, and it's pretty well known that these kind of trials tend to be more favorable to a positive outcome. They tend to be a little kinder to the medication under test. They're not quite as stringent as the randomized double-blind placebo-controlled trials. So probably the real answer with remdesivir in real life is going to be somewhere in between those two. That would be my guess. What's the efficacy in convalescent plasma? Well, there's no published data. We were the first to publish our first 25 patients. We showed it was safe. The next 325 patients have also shown that. There's a big national cooperative trial that has now enrolled over 5,000 patients, also showed very good safety. Efficacy is obviously under analysis, including here at Methodist. Our investigators chose the retrospective matched cohort design because they did not want to risk the infusion of a large volume of placebo in sick patients. I'm not at liberty to reveal these results, but they will be out fairly soon. Next slide. So the big news in the last month or so has been dexamethasone. This was a very, very well-controlled, very high-quality trial conducted in the United Kingdom of a very well-known, been around for years, very cheap corticosteroid that reduces inflammation. And this reduced death in patients who were the most critically ill, being mechanically ventilated by 35%. Huge statistical significance, p less than 0.001. It also reduced deaths in patients who were not sick enough to require intubation and being on a ventilator, but who were needing oxygen. It reduced death in that group by 20%, and that was also statistically significant. Now, something I want you to keep in mind is that when they looked at the group of people who were sick enough to be in the hospital, but they weren't requiring lots of oxygen, they weren't requiring ventilators, there was no benefit to those people. And although not statistically significant, there may be even a trend that people who got the steroids did worse in this group of moderately ill patients. And that's super important because it makes the point that even an effective treatment cannot just be given in a sort of blanket way. Well, this works, let's give it to everybody. It doesn't work that way because this disease is a very protean disease. There's a viral replication phase early on where you want your immune system to be at its peak. Later on, there can be a phase where there's not that much virus left in your tissues, but your immune system is perseverating, going on, and starts to attack you. These phases of the disease have to be treated in very, very different ways. Next slide. That brings me to budesonide, which we got a lot of questions about. This is kind of the hot thing lately. It is a corticosteroid like dexamethasone, so it reduces inflammation. It's an approved drug. You can get this by prescription. There are two forms of it. For people who have asthma, it's a preventative prophylactic that can be given by an inhaler. And for people with inflammatory bowel disease, there's a pill form of it. Now, one small study in the test tube looked at it against the COVID virus and found really no significant effect. But yeah, it's hard to know what that means. So in fact, Oxford University in England has begun a clinical trial on this called STOIC. I think everybody's looking forward to seeing, in a really well-controlled trial, what's the right way to use this? What groups of people does it help? And how big is the benefit, if any? Because what you have to recognize, and I'll throw a little cold water here, is that everything that I've seen about this drug, I've looked at all the YouTubes and I've seen all the press, stuff. It's all a bunch of anecdotes. It's not proof. Now, when we apply scientific tests to it, it may turn out to be fabulous, but we don't know that yet. Couple of issues. One is that the people who are popularizing inhaled delivery, you got to remember, COVID-19 is a systemic disease. It's not limited to the lungs. You can find the virus in your mucosal tissue, in your guts, in your lungs, in your heart, in your blood vessel linings. So just inhaling a steroid may or may not be the ideal approach. And again, remember, during the early phase of infection, suppressing inflammation could potentially be harmful. So intriguing medication, more to come on this. I got 2 slides on hydroxychloroquine because there's too much to say about it than I could fit on one slide. But basically, I'll try to keep a high-level view here and just say that there have been sort of 3 phases of our understanding of this medication. The first phase, prompted by a small French study of hydroxychloroquine combined with azithromycin, which is an antibiotic, claimed incredible results. A lot of political leaders, the Food and Drug Administration, everybody rushed to roll this drug out because they thought it was going to be the answer. Phase 2 was marked by a ton of negative data, negative studies, negative press releases, and I call this the not-so-fast cowboy phase. 2 different studies in New York. One said it was ineffective, although there were more cardiac arrests in the people who got HCQ, because it does have an effect on cardiac conduction, which is a potentially lethal toxicity. The other study showed that HCQ was actually associated with higher mortality in hospitalized patients. Then waters got muddied by this paper that came out in The Lancet, one of the highest profile medical journals in the world, that again piled on to HCQ. And sadly, this paper was later shown to be not worth the paper it was printed on. And that has cast doubts on a lot of the other negative studies. Well, if that one was a fraud, what about these other ones? This group that's doing the really great clinical trials in England, it's not on the slide, but they also came out with a negative result. They said it was not effective. So the FDA turned on their heel and revoked the emergency use authorization. 2 weeks later, they doubled down and said, you really shouldn't use this at all outside of clinical trials or hospitals. The World Health Organization stopped their clinical trial of the medication. National Institutes of Health here in America stopped their clinical trial because nobody would enroll in it because everybody had seen all this bad press. This stuff is terrible, it'll kill you, it doesn't help you, nobody wanted to sign up for the study. So the next slide shows that we're now in a phase where there's some positive data coming out. And everybody is, kind of feeling like, I think the coyote in the Roadrunner cartoons, like, what in the world is going on here? And I think the answer to that question is we don't know. There have been now 5 that I know of studies of hospitalized patients, and again, retrospective studies with retrospective matching, not the strongest study design. But they have shown, high degrees of reduction in mortality in a couple. The Henry Ford study, which is probably the one that most people point to lately, you got to be careful because twice as many of the patients who got HCQ were also given corticosteroids, which we have seen by themselves in very high quality studies are quite effective. We've looked at our data here and we've seen no effect on mortality, but also no toxicity. And then we see this outpatient study from New York, from actually a family practice that showed dramatic reductions in hospitalization. So we don't really know at this point. I think the betting would still be that this is not a terribly effective drug, but I think it deserves further study. And in fact, we are hoping to stand up a study here in Houston of HCQ plus AZT plus zinc, just like this New York study, and give it a proper test with proper controls. Last slide, vaccines. And I think perhaps for the next town hall, I'll do a deeper dive in vaccines, but just to briefly say, there are basically 3 lead horses here at the moment. The Moderna vaccine, the Pfizer vaccine, and the Oxford vaccine. They are all trying very hard to be in a position where they can get emergency use authorization from the FDA before the end of 2020. If I had to bet on one of them succeeding, I would bet on the Oxford vaccine. There are some questions about its potency, but its safety is extremely well documented. And it's really about to go into phase 3 trials with 30,000 people in Brazil and South Africa. Obviously, when you're testing vaccines, you got to go where the most sick people are. Moderna and Pfizer are also pretty impressed looking so far. Again, not to throw too much cold water, but vaccines have to get across the finish line before you can breathe a sigh of relief. So that's a quick tour through what's going on at Methodist and around the world. And if I have time, I'll answer a few of the other questions that I couldn't get to in the presentation. Thank you.
Well, thank you, Dirk. Very much appreciate that look at the very complicated data on a number of those drugs. I'll talk a little bit later about how messy science can be in real time, and I think you've just given us a perfect example of that. So now I want to turn to Dr. Nasir, who's going to talk to us about some of the long-term impacts of COVID. As we go through this pandemic, we're recognizing and beginning to see early signs of some longer-term unfortunate sequelae of this, and he's going to brief us on that. Dr. Nasir.
Mark, thank you so much. Great presentation, Ellen and Dirk. So, as of yesterday in US, the pandemic has affected almost 3.5 million people, about 140,000 deaths, and rightly so. As frontline workers and most of our patients, the first task is really trying to get out of this disease. But I think this may be one of the few battles that we're fighting. And the next question that we have little idea is, what is going to be the long-term consequences of getting a COVID-19 vaccine? So although in the earliest phase of this pandemic and this new global world order, but what we truly need to do is assess this more systematically. And for that, I've always appreciated Donald Rumsfeld's approach, depending upon your political affiliations, but his issues on focusing on knowns and unknowns becomes very important. Now, we've been in a great position that over the last many months, there is an exponential increase in the knowns, and thankfully that due to the global sharing of data by our colleagues all across, which we haven't seen. But at the same time, as we expand what we know, we are also learning a lot about what we don't know and we should know. But at the same time, I also caution we need to be nimble, and we need to understand that there are going to be a lot of unknowns that we don't know. So let's be prepared. What have we learned over the last few months? Of course, what does this virus do? There is a direct cytotoxic effect. Secondly, it affects the ACE2 inhibitor, which causes dysregulation in one of the pathways, causing vasoconstriction, injuries. And as Dr. Lumsden pointed out, huge dysregulation of the immune system that would create significant inflammation, although it primarily affects the lung, but now we are seeing multi-organ involvement. Just over the last 1 month, there have been significant emphasis that maybe it's not just about the inflammation. Actually, it starts with the lining of your vessels, causing the platelet to activate and get your clotting system out of regulation. Now, what we have seen is we are gaining significant clarity. Now, autopsy studies have added to what we have learned from these basic science studies. The first autopsy study that came from Italy clearly showed those acute changes in the lungs that we have well known about in the prior pandemics of SARS, MERS, and also with severe flu. When further studies extended, for example, looking at the heart in Louisiana, they found that actually we weren't seeing too much inflammation in the heart. It was those smaller clots in those small blood vessels. And now data just last week coming in from New York, NYU, as well as Mount Sinai, that actually almost every organ is affected by clots, whereas you will find very limited inflammation, something that we didn't expect, but this is a known that is becoming a fact for us. Now, coming back to the clinical side, of course, we have always anticipated that the lung function and the lungs are going to be the most effective. So the first question is, when patients are being discharged after getting COVID, how many of them have decreased lung function? Almost everyone. That's kind of, if you take 100 patients, almost everyone at the time of discharge would have a reduced lung function. Now you tie that to their imaging studies, and of course, most of the individuals get the worst appearances of their lungs on the CT scan almost at the peak of their disease. But even at the time of discharge, 94% of those individuals have residual disease. Now, this new publication that came out a couple of weeks back followed these individuals for at least a month and a half. All of these individuals who had severe disease, for example, requiring oxygen and ventilation, still have residual ground glass opacities. However, those who had mild form of disease, at least 1 in 3 of them still had those signs. Now, while the lungs are well known, I think so the kidneys have been flying under the radar. What we learned last month from a large study from Northwell, that almost 1 in 3 will have some kidney damage. However, 1 in 6 will require dialysis. And most of them are the ones who need some ventilation. If you don't need ventilation, only about 1 in 500 would do that. Now, what's the mechanism? Most of us think this is due to reduced blood flow, ischemia, inflammation. But again, I would caution that we should not discount the clotting mechanism that's happening and what we have learned for the recent autopsy studies. Dr. Lumsden pointed out some of the early changes that we see in the heart. So while we expected that there will be some myocardial damage, but not in 1 out of 3rd. And once you have that, these individuals are going to be at risk almost 2 to 3 times higher. So during the early phase, we thought this was likely going to be due to inflammation, whereas however, the autopsy studies clearly showed that that wasn't the case. And now, even in the echo findings, that we should have found the left side of the heart, which is the main pump that gets affected with this inflammation, is basically spared. Most of the abnormalities are we seeing with the right side of the heart, which may be due to an increased clotting that happens into the lung. And a lot of individuals who are presenting with ST elevation, acute heart disease, or I would say heart attacks, they're not due to because they have a culprit lesion that gets blocked. It's actually, a lot of them are due to thrombus and due to all of those abnormal clotting that happens. Now, while you have changes in the kidneys, you see extensive changes in the lungs and the heart, the brain is also not spared. And this large cohort study from Spain, almost 1 in 2 have some neurological findings and brain damage. Almost 1 in 5 had issues of consciousness. A majority of them in these individuals, we also saw that they were also at risk for stroke, as Dr. Lumsden pointed out. And in this interesting brain imaging study, we were seeing clots at places that they shouldn't have been. So it's a different mechanism and not following the usual pathway, and we still don't have a clear understanding what's happening with the brain. Now, you've seen that this is affecting such a disparate group. People with different baseline risk factors can have different reactions. For example, if you look at this interesting tweet that happened, Greg Garfield, who's an avid skier, he was admitted in northern Italy for almost 2 months, was on the ventilation for 1 month, and went home on a walker and a wheelchair. Most of us anticipate that majority of our patients will recover without any long-term effect, but I would just add a little cautious to that statement, because we just don't know yet. In fact, last week, there was a big paper that was published in JAMA that looked at in patients who were discharged after spending almost 2 weeks in the hospital. And only about 12% were symptom-free. More than half had 3 or more symptoms, most importantly, as we know now, fatigue, shortness of breath, joint pain, and almost 20% still complaining of chest pain. Now, this is not just limited to those who got admitted. A lot of patients who don't get admitted clearly report the same symptoms. Even 85% of them who considered themselves healthy before COVID, now only 6% would say so. So now where does it take us? I've shown you a lot what we know, but these are the known unknowns. We are trying to get a hold on who gets long-term symptoms and why. Why are you having chest pain 3 months down the line? What about severe lung damage? We are seeing 1 in 4 individuals having fibrosis. The question is that going to be reversible? Are individuals going to require permanent dialysis? We have no idea whether there is going to be heart damage in mild cases who never got admitted. And rather than seeing right-sided, left-sided failures, are we going to see an epidemic of right heart failures? And the most interesting question is, what's going on with the brain? Are we going to see a pandemic of long-term cognitive deficits? There are effects of quarantine, social distancing, economic challenges, and we have seen patients now presenting with stress cardiomyopathy even without COVID. And one of the other issues that we also need to be mindful that how is it impacting our healthcare workers' stress level. Just quickly, one of the biggest unknown unknowns are what we saw. This pandemic clearly brought out into the open the disparities of the most vulnerable groups and how social risks were impacting their presentation and an outcome. And I think so it's a moral imperative on us to keep that into consideration, not only to study how these social determinants of health improve their recovery, but make every effort so that we can mitigate their risk and enhance their recovery and reduce the likelihood that they will have a high mortality, morbidity, and increased healthcare expenditures. So just finishing up from a Houston Methodist perspective, what are our options right now? And I think so at the leading edge of innovations, I think we've already begun to prepare for the future. We are not waiting until the details are known or fully understand. And we do not expect that other will address our concerns or solve our problems, as some of the data that's been shown by Dr. Sossman. And in this regard, I can just give you an update. And yes, we were prepared under the leadership of Dr. Sossman and Beta Cash at the Center for Outcome Research, an effort led by my colleagues, Dr. Wahidi and Dr. Jones. We started very early on in March in creating that basic infrastructure that we can collect data and create the pipelines, not only of those individuals who was SARS-CoV positive, but who also get tested. So as far for now, we have all the data elements for more than 2,500 individuals who get admitted, and continuously to enroll those who will, but also about 5,500 individuals who did not get admitted. Now, where do we go from here in trying to understand the roadmap? I think so this is a great opportunity for all the clinical and research stakeholders that we can all come together to leverage this infrastructure. And we can come up with building an integrated COVID clinical research programs where we can understand the recovery, the quality of life, whether your lung function is improving, what's going on with your heart and brain, biobank, so that not only we understand the recovery for our constituency, but also inform millions of individuals worldwide. And of course, in this efforts, we need to be collaborative partner with our TMC and national institutes. So to finalize, I just want to let you know that what we have learned that this is no flu vaccine, this is no flu. And as Professor Nicholas Hart, who treated Boris Johnson when he was affected, his thought is this is our generation's polio. And we need to be prepared for their recovery and rehabilitation. From Houston Methodist, I can say our legacy is standing on the grounds and serving our population in the biggest pandemic that happened before this. We came out with flying colors, and I think so right now we'll also triumph and make a mark on the history. Thank you so much. Thank you, Mark.
Thank you, Dr. Nasir. Really fascinating and sobering as well to see some of the long-term impacts and current impacts that we're seeing on so many patients, and why this illness affects people minimally all the way to so severely is still one of the great mysteries that medical science is trying to sort out. So I'm going to give you an update of where things are on the ground, and then I'm going to talk a little bit about where we're going from here and where I think we should go from here. So let me start by saying what a difference a month makes. This is the chart I showed you last month on June 11th through the day before. You can see that big mountain we went over in early April came back down. We're starting to creep up, and of course you'll remember I was sounding the alarm bell at that point in time that we felt like we'd let our guard down, that we were going to see increases. Here's the graph today. That mountain in early April, unfortunately, was just a foothill, and you can see the major mountain we've been climbing. Now, you'll start to see maybe some signs of encouragement in our data. I'll come back to that as we look at some community data, but you can see here, as of last night, we had 700 patients total in our hospital. Thankfully, most of those are non-ICU patients. That's one of the big differences we're seeing this time around. But still a very large number of ICU patients you see in gold, as well as what we call IMU. Think of it as in between the regular hospital beds and the ICU. Either sometimes people coming out of ICU who need a little more specialized, higher staffing ratio care, or oftentimes somebody where we're really trying to stave off keeping them out of the ICU and using those beds. Frankly, if we were seeing ICU utilization like we saw last time, which was about 40-45% of patients, we'd already be completely overwhelmed at this point across the medical establishment in Houston. Fortunately, we've seen some significant differences in the population this time, and I'll come back and talk about those in a little bit. Similarly, if you look back in June, we had cared for 2,600 patients who we had diagnosed with COVID, admitted 1,100 back on June 11th, just about a month ago. Here we are today, 11,700. We've got 3,800 people as of yesterday admitted. This is a massive, massive change over the last month and a massive increase that we've experienced. These are the testing data. So what you see here in the blue bars are the patients we've tested positive for COVID. So even at the peak in early April, our highest day was slightly over 100. You can see we came down and we were testing a pretty small percentage of people, and in the orange that were positive. And in the orange line, you see the percentage of tests we were doing that were turning out positive. So for a short time there on that first peak, that came up to about 30% of the tests we did were positive. But we got down into the 3 or 4% range for most of the month at the end of April and most of the month of May. Today, as you can see by the orange line, we're testing a solid 25 to 30% of people. That's a 7-day rolling average. And you can see the peaks of each of those. We have tested as many as 551 people just at Houston Methodist positive in a day. Don't get lulled by the last couple small ones. That's a weekend effect. When you look at the next day, it will be much higher. But you can see at least, thankfully, that the percentage positivity is leveling off, and you can see some flavor of perhaps some leveling off in the testing data for Houston Methodist. These are the testing data across our entire region. So we report these through the TMC, but it's actually external data that's just re-reported. Now here, what you see in the bars is you see the daily number of cases positive in the greater Houston area, 9-county region. In the red, unlike the other one, which was test positivity, this red is a 7-day rolling average of the positive tests. So it gives you an idea of where we go. And what you see is on June 25th, we peaked, thankfully, and started to actually level off at a very high plateau. As you can see, this was a plateau, depending on the week you were looking at, somewhere between 1,500 and 1,800 positive tests a day. What's concerning me is that you see there now, about 8-9 days ago, our 7-day rolling average began to climb, and it's climbing more now. And yesterday we saw a record number, just under 3,000 cases. If you recall, we were predicting, in fact, we wrapped the Houston Chronicle, we put out billboards, we did a massive social media campaign urging people to behave differently over the 4th of July than they behaved over Memorial Day. I do think that was successful, but I don't think it clearly was entirely successful. My prediction is that the curve you're seeing here is right on time to be the result of a 4th of July where people let their guards down again. So what we don't know right now is, will this keep going up, or will this will this level off? At this point in time, we have a masking order, as you know, mandatorily through the state. Bars were closed. Those are probably the two major actions that have happened. No question those have helped. If you look at the timing of this, there's no question this curve bent because of that. What we don't know is the impact of the 4th of July. We don't know if that's adequate at this point. All we've seen is a plateau at an unacceptably, very challengingly high level, and we don't know if that's enough to bring that back down. We don't know, and you see a lot of political discourse about this right now, whether another shutdown will be necessary. I will tell you, if this curve keeps going like we see it here, and if we don't see the plateau coming down, I think we're all but certain to need another shutdown for some period of time in the near future. Thankfully, at the hospital side, we're hanging in there right now. And so in terms of, do we need that today desperately? The answer is no. But as you look at the hospital data, we bent collectively. You saw, of course, Houston Methodist data around the same time, about 8 days after the testing bent, right about when you would predict it. Well, we're about to enter the phase where we're about 8 days post the testing side going back up again and starting to shoot up. So this next week's going to be really critical and interesting as we look at where things go going forward. But I am very concerned about what I see here. I'm very concerned that we may be in a situation where we have no choice but to end up in a shutdown again. This is a complicated slide. It's available on the TMC site daily. You can pick up the new version of it each and every day. It's really our attempt to communicate what is a very, very challenging to communicate topic You've seen a little press about how confusing that can be, and quite frankly, and I'll talk about this later, how really voices on either end of the political spectrum have chosen to use the same data, basically make opposite points. The fundamental box I'd encourage you as you watch over the next few days and weeks to look at is that small little green box in the middle. What that does is say how much of what we call phase 2, which is really now starting to get into some more challenging expansion of ICU, bringing in external staffing, et cetera, how much of that's in use. Thankfully, it's pretty low, but right now it's been kept in check really because we've rolled back a lot of the inpatient cases that can be delayed that demand ICU and other bed utilization. So whereas we were down to 54% of beds being utilized in phase 1 across the TMC, right now 51% of beds are being utilized for non-COVID patients in the ICU setting, which is probably about as low as we can go because of course most ICU utilization is not planned. Most is a result of very sick people, and of course we desperately do not want to see the kinds of things that were reviewed by Dr. Lumsden in terms of some of the harm that has happened to the public because of fear of hospitals and avoidance of hospitals. This is an oldie but a goodie, a slide that I showed back at our first session back in April, just to show our planning. I bring it out again, really not to go through it in great detail, but just to remind everybody that as we move into this next phase, we're starting to stretch our staffing. It is tiring for our staff. We spread them out. We end up needing people running overtime. We bring in new staff. But if we have to keep on marching up, there are consequences to that. This will not be normal staffing. This will be pandemic type levels of staffing where we extend teams of intensivists, we extend teams of nursing to care for sick people. So it's really incumbent on us today to get this curve in control and not put our society and our hospitals and our employees in this type of situation. So based on all the data, TMC has a projection that we do. There's really two inputs in this, and you'll see in the darker blue lines at the bottom, that's the medical surgical beds, and the lighter blue up top, that's the ICU beds. And you can see we're in what's called phase 2 for all of those entities, thankfully not too deep into phase 2. There's really two inputs into the projections. One is what's the last 7-day growth rate, and the other is where do we start? And so this will fluctuate each and every day. Thankfully, you see this has leveled out for the last 2 weeks or so. We've had a projection that says we've got about 2 weeks until we need to go to phase 3. That's because we've cut back on other procedures. We're using less beds for non-COVID patients. And it's because now we've seen some slowing in the data, which is a really good thing, but one that we're not sure obviously will stick. So this is something I encourage you to watch closely. We are certainly watching this closely as we go forward. Now there's some good news in everything we do and everything that's happening. And that's that mortality has really declined very significantly. So whereas you look at that first beginning of the curve, we were seeing mortality, once it stabilized, probably in about the 12% of patients who were admitted to the hospital would pass away. Now we are on an accumulative basis down to 7%, which of course implies that we are even lower than that today. That's pretty remarkable. And let me talk a little bit more about that in detail. So here what you see in the upper left is the number of patients in March, April during that first surge. Then in green you see May, and then in dark blue you see June. And then in that bright blue on the right, or the blue on the right, you see July month to date through yesterday. So first off, you see how many people are coming through and going home in our institution as a result. On the bottom left, you see the number of people who have actually died during those time periods. So even though, as you look at the upper right, the mortality rates have come down dramatically during those times, far more people are passing away now because, of course, we have huge, huge numbers of patients coming through our institution. What you see on the upper right then is the mortality rate, and we have learned a great deal. We've seen this come down. When I was speaking to people around June 20th, 25th, when I would see these June numbers, I was telling everybody they're too low, they're not accurate, because we knew this bolus of patients was coming in the back half of June, and those who were sicker would stay longer before they passed away. So the July numbers probably reflect a little more likely what we're going to see as a steady state. I actually think it may even be a little higher than that, probably in that 6.5% to 7%, it looks like. This is a testament to many things. One is we've seen a younger age distribution of patients, so that is a good thing, obviously, in terms of outcomes, our ability to respond. It's really, to me, a reflection of the fact that, the people who are more vulnerable, the people who are older, were more careful. It's also a reflection on the flip side then that some of the younger who maybe got the wrong message that they're invulnerable somehow, went out, let their guard down, acted like this never happened, and we began to kind of load this, around Memorial Day and on and on and on, and have gotten in the situation we're in today. It's also a reflection of the care that's being provided. There's no question. You heard a lot of that today. Remdesivir, convalescent plasma, corticosteroids, proning, which is keeping people on their stomachs, avoiding intubation, because we know intubation, when you put a breathing tube in, was harming people's lungs and actually doing a lot of lung damage. So if we can avoid that, which is, now that we avoid that, it's 180 degrees from what they were telling us back coming out of February from China and from Italy. And all of those things together, and not the least of which is we now have clinicians who've been caring for patients with this for well over 4 months, and experience matters. Obviously our surgeon, Dr. Lumsden, would tell you that people who do lots and lots of vascular surgery or heart surgery have better outcomes typically than people who don't, and we know that nationally, and I think experience has been a key factor. The other factor we're seeing with the younger population also, and not just younger, we're seeing fewer comorbidities and fewer risk factors for the patients coming in. So that's also leading to better outcomes. It tells me there's a group of people who are out there saying, hey, I'm fine, I can go out there, and a group of people who are protecting themselves. But of course, eventually that catches up with us, right? You can't have this running, rip-roaring through a healthy population without starting to creep into a less healthy population. So we watch the age distribution, we watch those data very carefully, because we're very concerned that we're going to see an uptick back in the mortality data going forward. And then just a couple things to end with before kind of a phase 2 of my talk here after the data is to say, look, across the US, actually, we're doing pretty well from a case fatality rate. In Texas, and this is ordered by the number of cases per state, so we're the 4th busiest state in terms of number of patients who've been diagnosed. We were 3rd until Florida just overtook us again. You can see how well we are doing in Texas from a case fatality rate. Look at Harris County. 1%. I think there's a whole host of reasons for that, but it's rather surprising given the prevalence of obesity and prevalence of diabetes and other issues in our community. And so this is something I think we should be proud of. I think it's a testament to a lot of good things in our community going on. So I want to shift gears now, and I want to talk really about why we're in the situation we're in, where we're going, what we need to do. I'm going to speak up here. I'm going to speak my mind following Dr. Martin Luther King's advice here, which is, we need to talk about the things that matter. So I want to first talk about, to me, the 5 most important things that we as a society have to do if we want to get control of this, if we want to move forward, and if we want to have any semblance of a normal or semi-normal life, economy, schools, etc. First and foremost, unity. I don't think any of us would disagree with the fact that we have a tremendous, profound lack of unity in our community today. I love this quote from Winston Churchill. It's written a little bit kind of old speak, but let me read it to you. My hope is that the generous instincts of unity will not depart from us, so that we become the prey of the little folk who exist in every country and who frolic alongside the juggernaut car of war to see what fun or notoriety they can extract from the proceedings. Doesn't that just describe the situation we are in today? Whether it's the press, whether it's the internet, whether it's snake oil salesmen that we see all the cures that they're purporting out there without doing a study. This is the situation we find ourselves in as a society today. And we as a group of people here on this call and in society, we have to change this if we are going to move forward. Unity is an absolute necessity to every single other thing that we need to do. In the words of Dr. Martin Luther King, we must all learn to live together as brothers, or we will all perish together as fools. So why can't we as a society pull together today and do the things we need to do? In the words of Mahatma Gandhi, unity to be real must stand the severest strain without breaking. Our unity as a country is being strained. Our country is being tested. Frankly, I think we're failing. And our will as a people is being tested today. We need unity. Going back 2,400 years to Alexander the Great, he recognized that the conduct of each of us determines the fate of all of us. We've known this for 2,400 years. Why can't our politicians learn this? Why can't we as a people learn this? We've become soft. We're treating this instead of like World War II, where everybody rallied together. In phase one, we did that back in March and April. Instead of rallying together and doing what we need to do as a people to conquer this threat, we're acting like Vietnam. We're acting around a war that we don't want to be in, that we're debating whether it should be there, and we're throwing bombs at each other instead of at our threat right now. How sad is that as a country? We don't determine whether or not this virus exists. This virus came at us. This is like being attacked during Pearl Harbor. And I don't understand why we as a society cannot pull together and do the right things that we need to do to get this under control. We need unity. And I'll end this piece of my talk by a much more inspirational phrase here from Helen Keller, which is, together we can do so much. We can do this. On this phone and on this presentation here, we have leaders across the great city of Houston. We're Houstonians, we're Texans, we're Americans, and we're human beings, and we can pull together and we can show the leadership together, we can push our politicians, we can spend the money we need to spend, and we can demand the best out of all of our leaders to make sure that we can move forward together as one to tackle these issues. So now I want to move to 5 specific things that I think we need to do as a society. I mentioned this before. We acknowledge and recognize science, especially biological science, is incredibly messy in real time. Just look at those 2 pages of hydroxychloroquine slides that Dirk said, and at the end of the day, we still don't know the answer to that. This is the nature of science. Unfortunately, we have to do this in real time. Science is also the only hope we have to conquer COVID. There's a lot of hope in the slides you've seen. There's a lot of hope in what my colleagues have discussed today. There's a lot of hope in the fact that we have gotten mortality down like we have. There's a lot of hope that when we know the things to be done, we can get this in control. So let's listen to the scientists, let's listen to the physicians, let's tune out the noise and the voices on either end of the spectrum, and let's figure out how we as a society do the right thing. Now, many of you will have seen a letter I wrote, my president's letter in June, which I called the sacred and. For me, for hospitals, and you've seen some of the data today, that is that we have a profound responsibility to care for the community, to be here for patients with COVID. We also have a profound responsibility to care for all other patients, and we have a profound responsibility to protect our staff and our physicians, whether that means the PPE, whether that means the fatigue and the burnout that they're experiencing, or whether that means their financial livelihood. All of those are noble goals, and we will unapologetically focus on each and every one of those goals. And I can't tell you how hard this is to communicate to the press, to the politicians, to the general public of what you heard today, which is we know how to care safely for people who need care, who don't have COVID. At the very same time, we are, killing ourselves right now caring for patients with COVID. Extremely importantly, and this is what we all need to demand, our political leaders have a sacred and as well. They need to figure out how to control COVID and listen to the scientists and listen to the physicians, and figure out how to protect the economy, and figure out how to educate our children. These are not ors. These are not false choices that one side versus the other side are putting out there right now. They need to link arms. They need to figure out how to work together with the rest of us and figure out how to move forward and get this done so we can do this together as a society. A lot of you have asked questions about schools. There is no way on God's green earth that we can put our kids back in school at the levels of virus that we have here in our community today. It's not going to be realistic, I don't believe, to expect that, certainly with what we've done so far, that we're going to get that in control by mid to end of August. So I would expect we're going to need to have our children back in virtual school until we get this in control. But the goal needs to be get them back to school. The negative impacts and the social inequities that Dr. Nasir talked about are getting profoundly magnified by the fact that we can't get children back to school, by the fact that our economy can't be protected. The source of all of this is this virus, and there are things we can do together to control it and make sure we can do those other two. Our social lives are going to have to take a back seat to the sacred and. If there's one thing I think we've seen since we started to open up, now 2.5 months ago, it wasn't the opening of the businesses that were doing things safely. It wasn't getting people back to work. It probably wasn't even shopping or some of the other things like that. It was our social lives. Now, we sent out, and our politicians sent out, conflicting messages to all of society. So people heard, I shouldn't wear a mask. People heard, well, I should just do whatever I want to. And we got into those debates. And so we have to acknowledge and recognize bars, and our politicians need to figure out how you support these small business owners. They're incompatible with a pandemic. Probably, honestly, restaurants in person are as well, certainly at 75% and up levels like we got to. I will tell you, I personally still have not eaten at a restaurant, and I have no plans to. I take out all of the time to support restaurants that matter to me. We are not going to be able to have large gatherings, including sporting events, and we must figure out how to limit social gatherings. You know, I talked about World War II. If we can do the things together as a society to successfully challenge an enemy during World War II, can't we do these simple sacrifices together to get this virus in control? And then finally, masks are a means to an end to accomplish the sacred and. Where we went so desperately wrong is that the people pushing the economy, who have a very fundamental, valid point, as I hope you've heard from me, to open our economy, get our schools back, were the very same people in many cases who said, well, yeah, but don't wear a mask. There's no reason to wear a mask. We've shown as a society we can't seem to accept this on our own. They need to be mandatory. We're going to need to keep them mandatory until this virus is in control, and we're going to need to put enforcement in place in order to do that. Certainly, this is the perfect cartoon to describe what we have out there right now about masks. You know, there was a study or a case report yesterday that came out that I saw on a hair cutter who found out that she had COVID. She'd had 139 clients go through her office during the time it was thought she was infected. She did everything right. She was wearing a mask. Her clientele were wearing everything she was wearing. They were wearing a mask. Not one of them got sick. We know this works. We know this can diminish transmission. We need to pull together to do this. So with that, a couple of questions y'all asked specifically about our people. One very lovely said, I'm concerned with how Houston Methodist staff, doctors, and nurses are faring. If I was to be honest, I'll tell you one thing is they're fulfilling their God-given calling, and they are doing just His work on earth. It is amazing to see them do that. But they're tired, they're fatigued, they deal with loss every day. They deal with challenging situations every day, and they look around at the community and they say, what is going on while we are watching somebody struggle to breathe, and our community can't do something as simple as staying home, staying out of social situations, and wearing their mask. They're frustrated, they're disappointed, to be honest, a little bit. You probably hear that from me as well, and it's completely understandable. We need to support these heroic people. They cannot run this marathon for years on end. We need to find a way as a society to lessen this burden on these individuals. And you've also asked, how can we help? How can we thank them? I want to thank each of you for the amazing gifts you've given. We gave our Heroes Day out. We gave a $100 gift out with our Heroes Day. Meals have come in, cards have come in. But honestly, this phase 2, instead of feeling unity and feeling all the support, they see a lot of the division in society. They see the garbage out there on the internet. They don't feel that same level of support. So if anything you can do to help, it's as simple as a tweet, it's as simple as a social media post, it's as simple as a thank you note, it's as simple as some people getting together and buying meals for an ICU team. All of these different things that are happening, these folks need to hear your thanks and your gratitude because they're tired. They're seeing difficult situations. We've had 2 people under the age of 30 over the last 2 weeks pass away in one of our hospitals. One died within 5 hours of arriving. The other put up a fight for a couple of days and passed away. We have a young mother at one of our hospitals right now delivered twins and is intubated after delivering twins. this is the real deal, and people are getting extremely sick at all age ranges for our institutions. So I want to end with an up note, another quote from Martin Luther King, because while we have some finite disappointment in life, I am an optimist, and we can never lose infinite hope. And so with that, I'd like to leave you with a quick video of thanks that you have helped put together to support our staff. Thank you. Dear frontline heroes, you are doing amazing things during these unprecedented times of COVID-19. You have astonished us with your brilliance, innovation, and compassion. You inspire us all.
You continue to uphold our eye care values as we unite to fight this pandemic.
Your bravery, dedication, and commitment to bringing innovative treatments and therapies to our patients inspires hope, not just for COVID-19 patients, but for all.
You continue to lead medicine while upholding unparalleled safety, quality, service, and innovation.
And you continue to put your life on the line every day to help our neighbors.
Words cannot express how brave, selfless, and heroic every one of you are.
You are making a difference in our patients' lives and the Houston community.
We are forever indebted to you.
We are so grateful to you for taking such good care of our families and loved ones while you sacrifice time away from yours.
Thank you for waking up every day, choosing to keep up the fight.
Thank you for never giving up on yourself or your team.
Thank you for holding our patients' hands when their families can't.
Thank you for your courage,
for your strength,
for your resilience.
Thank you for giving us hope,
for your compassion,
and for your innovative research.
Thank you for giving us the gift of your time,
and for remaining committed to serving all patients throughout this pandemic.
We know the sacrifices we are asked to make
pale in comparison to the sacrifices you make every day on our behalf.
For all you've done and all you will do, we say thank you today.
Thank you.
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 We are proud of our Houston Methodist COVID-19 heroes.
The work you are doing is divinely guided.
We are keeping you and your families in our prayers.
We are with you, praying for you daily. May the Lord be with you.
From the bottom of our hearts, thank you. We are with you every single step of the way. Houston Methodist, we can and we will prevail. Welcome back, everybody, and thank you to everybody who helped us with that video. I can't tell you how much that is appreciated. And thank you to each of you for all of the tremendous support you've been providing to our staff and our research teams and everybody else throughout this pandemic. It really has been heartwarming to see, and I want to thank you again from the bottom of our hearts. So we've run a little bit late, but we wanted to take and answer some of the questions that have been coming in today as well as had come in before. So by all means, pop off if you need to, but we're going to try and spend a few minutes here with a couple questions. So I'm going to start with one that came up on the board that I'm going to answer quickly, and then I'm going to turn to Dr. Lumsden after that for a second question. And the question on the board is, with a significant investment that's happened in contact tracing, what are we finding out about the drivers in the increases we're seeing in positive cases? So it's a great question. I will tell you one of the places where I think collectively we are not doing everything we need to. To be honest, right now it's a little bit moot because we're in mitigation mode. But through the month of May into June, and then now hopefully where we'll get when we get on the downside of the curve, contact tracing is critically important for us. Yet we are still undermanned at the county level, at the city level, at the state level. It still lacks coordination. They use different data systems, and quite honestly, the data has been slow to be forthcoming out to the rest of the health institutions. We've had some progress on that over the last week to 10 days. Kudos to them for that. So I wish I had better trending data than I do. I can tell you internally what we see anecdotally, as well as some tracing. I can tell you, talking to employers who've taken tracing into their own hands, we're seeing that bars, restaurants, social lives have been the most common place that we are seeing these kinds of connections. We don't fully understand why some events are super spreader events and some people are super spreaders versus others, but that has probably been the most common thread that we are seeing there. We're also seeing a big uptick in more socioeconomically vulnerable populations. We've seen the average income of the zip codes from whom patients come has gone down dramatically. We've seen a very large increase in the Hispanic population during wave 2. And especially in a Spanish-speaking only part of the Hispanic population. When we talk to our case managers and social workers, we actually have about a $300,000 campaign right now of getting education out specifically in Spanish language, trying to take some of the education into our own hands. I think our judge has done a really good job, obviously, with a lot of bilingual communication. It's been a big priority for the mayor as well. But what we see is people who are working frontline jobs, people who are working multiple frontline jobs oftentimes, people who may not have had the benefit of the same education that others have gotten, people who live in cramped quarters or multi-generational family housing, apartment buildings and others are also at much more risk. And so we are very concerned about those data that we see. Now I'm going to turn to a question for Dr. Lumsden, because we had a series of aspirin clarifications after your talk. And actually, I'd like to ask both of you, because I got two big-time experts with me here to talk about aspirin. Maybe you could enlarge upon a little bit what you were saying, and then I'll ask Dr. Nasir to talk about that from a kind of population outcomes basis as well.
Yeah, so the big question is, why aspirin? I mean, aspirin has been around for such a long time, and yet in the cardiovascular world, it is one of the more effective agents. So why does it work? We think of aspirin as a painkiller. That's not what we are thinking about here. Aspirin works on what are called the platelets. These are the sticky cells that help form blood clot. So remember, we were talking about blood clotting. So when we have a problem with a blood vessel and we get vascular disease, it's very common. Most of us are still going to die a cardiovascular death, and that's related to something that's going on inside the blood vessel. And so we get hardening of the arteries. But what happens is the surface of that artery is interacting with blood. Blood is flowing across it. And when something happens to disrupt the inside of that blood vessel, guess what happens? It's the sticky cells, the platelets, are the ones that see where that disruption in the protective lining has occurred, and it starts and initiates the formation of blood clot. And so and that probably goes on in the background all the time. But in certain situations, it becomes critical. So when we have a plaque inside a coronary artery and we get clot which forms on top of it, the first effector cell are going to be the platelets. And these platelets are affected by aspirin. And so aspirin acts on the sticky cells that interact with the surface of the blood vessels. So when people are getting chest pain at home and the EMTs arrive, they're going to give you kind of aspirin. This is going to be the first thing. So here's a drug that's been around for a long time, and it works both in the emergent clinical situation, but it also works prophylactically. We use it for patients with any kind of vascular disease, by and large, are on aspirin if at all possible. Now, there are other drugs out there called Plavix. Plavix is like super aspirin. Works a little more effective than aspirin, but much more expensive. And so here you've got a drug which is incredibly effective and is very cheap. Now, Karam, jump in. This is something that you've worked on a lot.
Well, Alan, as you were talking about, one of the key things I was thinking is the biggest secret in medicine is, evidence is mostly uncertain. So, but what we have learned over the last 2 months is we were thinking about this is going to be more of an inflammatory condition, but what has come out, especially from basic science research coming out from Yale, clearly showed that endothelial damage is the precipitating factor. And you know what happens after that? It's the platelet activation. And now if you look at all the autopsy studies, you are seeing those microplugs in your brains, in your kidneys, in your liver, in your heart, all across. Now, the questions that's really coming up, and we're seeing this huge difference in New York mortality as well as the mortality within the Houston area, and we have been extremely liberal in treating patients with anticoagulation. Now, is that an underlying cause? The totality of the evidence suggests that anybody with COVID coming in, we should be liberal with that. Now, but the issue is, what do we do with patients who do not get admitted? I think, as you pointed out, if you don't have any contraindication, till we have the next wave of data, aspirin is a good choice. Now, moving to the Plavix, it may get a little complicated, maybe more potent. People are also suggesting there are some oral anticoagulants, the lower dose, that have shown in patients who had heart disease that reduces their risk. Should we even consider that? I think we all need to come together. There is an utmost need to come up with some more updated guidelines for the general public, but where the data has shown, as you know, it exponentially increases over the last week and a half, it's clearly pointing out that we should be more active in this space in controlling.
So if I were to summarize, for somebody who has COVID at home, if there's no contraindication, so they should be talking to their physician first.
Yes.
It might make sense to take a baby aspirin a day, for example, just to get some of that effect that you're there, and probably little risk of harm. Again, as long as they don't have a contraindication like a bleeding ulcer or some other things like we'd normally have. Well, that's very helpful advice. Thank you. Okay, Dirk, I'm going to turn it over to you. I'd like to ask you a couple questions that came in. You know, there's the mutation discussion about these strains in Houston, and is it more contagious? And I know our folks have been looking at that. Can you give everybody a quick update on that?
Sure, Mark. It's kind of a fascinating thing. What's happened is the virus has undergone the most tiny possible genetic change that you can have, and it's had a big effect on its behavior.
Okay, Dirk, I think we're having digital issues with you right now, so I'm going to move things on, and I'm going to ask Dr. Nasir. So a couple questions came in about genetic predisposition to COVID, blood type and COVID. Can you talk a little bit about what we know?
This is such a fascinating space. Way back in the SARS era in 2003, from North Chapel, actually they found out genetically, if you mutate the immune genes, which is a special TICM2, actually it made you more susceptible. Now, what we're seeing is majority and the severe cases we're seeing in males. Now, there is immunity receptor genetic called TLR7. The defect of that actually can reduce your immunity against specific viruses. Now, in women, we have two of those strands, so the likelihood that even if one goes down, you have an extra coming in handy. Now, that's being suggested. Now, the blood type is very interesting. The initial study came out from China that showed, of course, we have type A, type B of a combination, and an O where you have neither. We saw the highest number of mortality and the risk with type A, whereas in type O, they were protected. Now, what happens is if you have a type A blood type, you have specific antibodies to type B, and if you have type B, you have antibodies to type A, and if you have type O, you have antibodies to both of them. In 2009, researchers in Paris actually found that for the ACE2 inhibitor receptor, that is how the virus gets infected and comes into the cell, it blocks that receptor. Now, that's kind of the precipitating thoughts. Now, the question that comes is there anything I can do or get a genetic testing? At this stage, it's too early. I just don't think so that they may be more relevant. It's more of a chance what if your type A and B and O would be. Still, the best prophylaxis is masking, social distancing, that all the great message that you gave us. I wish there was a bullet that we had that could cure this, but those are the best treatment and prevention.
So I'm A positive, so I'm stuck, but
You're
there's
stuck.
not much I can do about that. So one of those things I just got to live with.
Yeah.
Let me, I think we lost Dirk. So I'm going to try and take a crack at the question he was answering, which was about the mutations, because I've spoken to our team, Jim Musser, who I think you'll have seen before.
Mark,
we got him back.
I'm back.
Okay, well, I'll let you answer then. It'll be a much better answer. Thanks, Dirk.
Okay, quickly, before the internet keeps me out again, there has been a genetic change in the virus. The way it's spreading in the population really does suggest that it's more infectious now, but it does not appear to be causing any more severe disease, even despite that. So I think people can relax about that.
Thanks, Dirk. And our team is sequencing furiously, literally thousands of patients' genomic sequences. We're seeing about 98% of patients now in Houston have that strain. So it is the dominant strain, but they've pretty emphatically said they don't believe it actually has a change in outcome associated with it. But that's a tough question to tease apart from a research perspective as well. One of the questions we got asked is about flu shots, and I think I've talked about that in here before, but the question was, what's the impact in Houston? Should people take a flu shot this year? And it's yes, please take your flu shot this year. In fact, we're going to be pushing, and we'd already been working with the Greater Houston Partnership, with the THA statewide, the Texas Hospital Association, 2 months ago to say when kind of August starts rolling around, late August, as we start talking about flu season, we need to have people vaccinated for a couple of reasons. One of which is, we're going to get into that. Is it flu? Is it COVID kind of situation, which can be very challenging? Another is, of course, the challenge on hospital beds and hospitalizations if we have a bad flu year. And the third is the combination of having both is probably deadly for most people, certainly most older people. That is a 1-2 punch that most people probably cannot survive, or many people will not survive. And it's entirely preventable, or certainly largely preventable. So we could get to herd immunity in vaccination status on flu if we would just get flu shots. Typically 45% of the eligible adult population gets it, so we got a long way to go to get there. Flu probably needs 70-80+%, but I hope everybody does get their flu shots. Dr. Nasir, so several questions about kind of testing, which is always a challenge. So here's one. I tested positive. I had symptoms for 3 weeks. I then retested. It came back negative, but I still have some sinus symptoms, cough. My taste and smell are not back completely. Am I still contagious? Why am I still having symptoms if I'm negative?
Well, all I can say is whoever asked the question, you're not alone. As we are learning right now, and this is one of the biggest mystery, what's causing these symptoms? We are seeing individuals 2 months out of their COVID recovery, testing negative, having fatigue, shortness of breath, chest pain, taste loss. A lot of them could be lingering effects of the inflammation that's happening with some of the brain as well as even your nerves. That's being speculated. Of course, we know from the shortness of breath, there are lingering effects that are there from the chest, residual disease. Now, that's why it becomes clearly important that during the recovery phase, it's not just the primary care. There needs to be a coordinated effort across the specialty where we try to understand who are these individuals. They've actually come up with the word of long overhaulers, that they keep on having these symptoms. We don't have much insights over the last 3 months. What we have seen that although the symptoms do last for more than 2 to 3 months, they are not really causing long-term, at least within this 3 months, I would say permanent neurological, cardiac, or pulmonary damages. However, the rehabilitation phase needs to encompass all of this. So again, that's another issue. Many institutions are thinking about COVID recovery clinics where we can not only try to understand, but also manage these patients.
So I think COVID's going to be, unfortunately, keeping our clinicians busy for a long time, both from the acute effects and probably some of the long-term effects, unfortunately. Dirk, a couple questions here around environmental exposure. One about an article in the Chronicle saying that it actually may linger in the air longer than originally thought. And the second, really, a person asking about wiping down surfaces and how significant an issue is it in terms of spread from objects, spread at a supermarket. Do you need to wipe down your groceries? Those kinds of questions. Could you tackle both of those? Because I think the data has been emerging and evolving on both of those as well.
Sure, and like a lot of this stuff, it's a bit of a moving target, but the answer to those questions is yes. You should continue being careful about surfaces. That's probably not as important as we thought it was initially, but it's still important. Personally, I don't wipe down all my groceries. I just make sure that I keep very firmly in mind whenever I touch something that hasn't been sanitized. As soon as I'm finished touching it, I go and wash my hands for 30 seconds with soap and water. I think that's easier and more effective than trying to wipe down every object that comes into your house. But you can certainly do that if it makes you feel better. It's clearly going to be effective. As far as the airborne issue, it's likely that it's much more complicated than we thought. There are droplets. There's also some airborne virus. On the other hand, the airborne virus doesn't seem to be as infectious as you see in, for example, measles. So it's clearly wearing masks, very, very important. And that's really the practical consequence of what we're learning. Thanks.
Thanks, Dirk. Okay, a couple that came in today, I'm going to read them off the screen here, and I'm going to ask Dirk to take them. They're both around donating plasma. One was, what's the optimal time to donate plasma for a patient, and can one donate if you're anemic? And the second is, as a former COVID-19 patient, my spouse donates plasma to benefit others. Is my spouse at any risk of losing antibodies by doing that and putting themselves at any risk? Could you tackle that, Dirk?
Sure. To answer the second question first, no, your spouse is not putting themselves at any risk at all. And thank you, and God bless that person. There's no risk in donating plasma. If you're anemic, you can donate plasma because we separate out the red cells and give them back to you. You do have to undergo some health checks and some checks of your blood, but in general, you can donate plasma.
The number one.
And the best time is a few weeks to several weeks after the infection. As I think one of the other questioners asked, there is some data that people who have a very mild or asymptomatic infection don't raise up a lot of antibodies, and the antibodies do tend to go down after a few months. So it's that kind of several weeks to a couple of months sweet spot.
Thanks, Dirk. Well, I'm going to wrap things up with couple of questions about vaccines. People are asking, especially when do we think they'll be there? When do we think we'll be through phase 3 trials? Would you take one if you were offered the opportunity to do that? I'm going to round robin this one. I'll start with you, Dirk. Give us your closing thoughts on vaccines.
We'll have some doses of a couple of vaccines before the end of the year, not enough to cover the population, but we'll see safe and effective vaccines starting to come out. If I had the chance to take one, absolutely. Yes, I would.
Great. Dr. Nasir?
Well, I'm hopeful from the Oxford study by the end of the year we may have results. Some of the US studies are definitely into the phase 1. I'm not too optimistic till the spring or next time this summer, but absolutely any of these trials, if they come along, I would definitely participate.
Yep. And I'll close by saying that I would echo your comments. I think we may have tens of thousands, maybe even into the hundreds of thousands of vaccines in the fall from maybe 3 or even 4 of these manufacturers that are going to be in later stage clinical trials. They're going to go to higher risk populations, like perhaps hospital workers, probably in high prevalence areas, like Dirk talked about, the one going to Brazil right now, because of course, if you're going to study whether a vaccine works, you want to try it someplace where there's lots of infections to see if you can prevent those. I think it's really realistically going to be well into next year. Our Operation Warp Speed from the Trump administration is a great thing. They are parallel processing all of this, spending huge amounts of money to get the manufacturing up and running. Sign me up. The second vaccine that has passed the early safety trials is there, and I will be signed up, as will family members. So With that, I'm going to bring things to a close. Thank you for those of you who stuck it out and your patience for being with us today. I hope you found this interesting, fascinating, maybe a little sobering, but also I hope a little inspiring at the same time. I really believe we as a society, if we show unity, can get together. We can do the things I talked about. We can conquer this, and we can figure out how we get our economy running consistently, how we get our children back to school, how we coexist with this virus for what's going to be a year to two. It just is. And I think we've all seen that very painfully this summer that is the case. So thank you all for your tremendous support. May God bless you and keep you safe. Thank you.
Thank you.